Perfect. So, hello and welcome to Academic Talks, a series by the AO Spine Youth Club, where we sit down with leading experts to explore the academic foundations of spine surgery. I'm Raresh Mishkov, and I'm joined today by my co-hosts, Raj and Sampum. And we are thrilled to be speaking with none other than Professor Richard Bransford.
Thank you for letting me join. Appreciate it.
Hi. So Professor Bransford needs little introduction in AO community. He's a trauma and pediatric spine surgeon with a global mindset, trained in both US and Australia, and currently serving as a chairperson elect of the AO Spine Education. And I hand over to Sam to discuss further.
Yes, Professor Bransford, he's also a driving force behind initiatives like the Global Spine Diploma exam, and is very passionate about preparing spine surgeons for real-world practical challenges. So, Professor Bransford, welcome again to our academics talk.
Thank you.
Right. So let's just jump straight into it. So when we are designing clinical studies involving patients with spine trauma, what would you say are the key considerations researchers should keep in mind?
Yeah, I think that most of my research to this point in time has revolved around spine trauma, and what I've come to realize is that it's so key to really think through every detail from the very start. Whether that's a retrospective study or a prospective study, because there's nothing worse than realizing halfway through or even after your first 10 patients that, oops, we forgot to collect something. And as a prospective study, you can't go back and change that. You can't go back and fix it. Retrospectively, you start your chart reviews, you start measuring whatever you're going to measure radiographically, you start collecting data from patient charts and realize that there's something missing that you wish you would have collected. And so, as one of my mentors told me, you almost need to write the paper before you even start collecting data, and then go back and fill in the blanks that you intend to have at every detail. You write the introduction, you write even the results section with blanks in it, and you write your preliminary discussion. And if you have your framework ahead of time and know exactly what your hypothesis is, then it's easier to then the easy part is just collecting the data because you know exactly what you need, and then you just fill in the blanks along the way. But I think, as somebody who made the mistake many times early on, and I would go through 100, 200, 300 patient charts, and you go, oh, I should have collected this. And now you're opening every single one again. You're basically exponentially increasing the workload. So I think that the design, similar to your question, the design is everything. And you have to know too, sort of what the gaps are that you're trying to answer. Because if you sit there and say, oh, here's a question I think is relevant, but you're not familiar with the literature that's already been done, you may already be answering a question that's known, and then suddenly you have a great manuscript, but nobody will publish it because they're like, this is not new, this is not novel. So the homework is always before you even open that very first patient's chart or x-ray.
That's really amazing, Professor. And as a follow-up, when you are developing a study protocol, what methodological aspects or common pitfalls do you think are most important to avoid?
Yeah, and I would say that similarly sort of leverages off of the first question. I think the pitfalls to avoid are if you've not done your research ahead of time, if you've not figured out the gaps, if you've not developed a solid methodology, then you're going to make your research project that much harder. And I think what most people do is they try and answer too much with it, and many papers read too much like a book chapter. Whereas if you can say, I have a very simple question, it's a yes and no, it's a black and white, it's we should or we shouldn't, then you have something solid you can stand on. But if suddenly you say, hey, I want to explore a particular fracture, and you're writing about here's an age distribution, here's a neurological component, here's a complications component, then the message can get lost in the paper because you've tried to do too much. And I've read far too many papers that read more like a book chapter, and really the key message can get lost with all the other minutia that people are trying to share to try and make it as thorough as possible.
That is a lot of great insight. Yeah, I really learned a lot there. So, um, the next segment, let's talk more about the challenges with doing some multi-center studies. I see you have a lot of papers where you did collaboration on both the national, international, and also global scale. So, multi-center studies are becoming more common nowadays as we're, better connected, especially in spine trauma. In your experience, what are the primary challenges of running these big multi-center studies, and how do you solve the main challenges effectively?
Yeah, I think, as you all know, one of the big powers in AO is sort of, the knowledge forms in spine. And that really that's been a massive advantage to bring people from different cultures, different nations, different perspectives. And, we've been working on the A3, A4 equipoise study that has been going on for the better part of a decade. And it was fascinating to look back and see that if we could go back to the beginning and start the design all over again, I'm sure it would look vastly different. We realize that there's a lot of data points we should have collected, could have collected, but again, that's challenging because I may say it's very easy for me to collect every X-ray at 6 weeks and 12 weeks and 6 months and 12 months. For other places, that can be incredibly challenging. For some places, they have very detailed electronic medical records that everything falls into place automatically. For other places, it's paper. And so when you're trying to design a national, international, multi-centered study, everybody has to be on board with the data points being collected, because suddenly if you say, well, we had a 50% fallout or even a 20% fallout, you don't really have the same power in terms of your ultimate answer as you would like. And I think we recognize that with the A3, A4 is that we lost some of our power with fallout and stuff like that. And suddenly what would have been in the highest ranked journal in the world suddenly drops to a second tier or even third tier journal because you don't have everything that's there. And so to really ensure that you have that buy-in, I would say equally is I think what is frequently underappreciated is just how expensive these are. We're currently designing an infection study now, and we realize that as a multi-center prospective study, that really the budget for that's going to be probably close to 1 million Swiss francs in order to really truly execute it with all the nuances, all the background support that has to happen. And so I think it's important to appreciate that up front, because equally, if you launch onto a multi-center study nationally or internationally, and you haven't truly calculated and have somebody who's an expert in that to calculate what you're going to need, then suddenly you say, well, we budgeted for 25,000 and whoops, we had to abandon the study because we actually needed 100,000 or 250,000 or whatever it's going to be. So again, I think just that upfront work to ensure that everybody is on the same page, every single little detail has been thought through thoroughly, that sets you up for success.
Thank you. Thank you. This is a very good, insightful answer. Building on the whole idea of challenges in research, now it would be also difficult to implement these materials into real life. So how do you see the challenges of implementing the EOSPINE guidelines consistently across different healthcare systems? And what do you think are the main barriers and how we could overcome them?
I think that we would like to believe that there is a guideline that that crosses every single barrier. And some people, it's like for some regions it's economic, for some regions it's social, for some regions there's insurance issues, access issues, whatever it happens to be. And I think we have to recognize that. And I think that if we have a solid guideline, and I think maybe these are easier to implement in the medical field, to say everybody should take this tablet. That's very simple. As surgeons, our expenses are substantially higher. We're talking about, should this patient have surgery, and maybe what that surgery is a different question completely, but that's a huge issue of access, of healthcare expense. And that's where it's hard to apply these guidelines across the board. We recognize that all things being equal, that there may be one thing better than another, but maybe on an economic level, it just is not better enough to say that it's going to be implemented everywhere. And we have to recognize that. I think if we can, I think we all recognize that everybody who has a incomplete spinal cord injury likely should undergo some sort of decompression and fusion. And I don't think anybody argues with that. If we discuss, you know, in A3, A4, should everybody have a surgery for a particular fracture pattern? Well, then we may say the nuances of operative versus non-operative, or some type of operative versus different operative, then it may not kind of balance out quite as well, and there may not be enough of a difference. And so I think guidelines are not, they're not absolute. They're meant to be guidelines to give us direction. But again, for every patient, there's various factors. There's the old, there's the young. You know, you may say that this patient who's 85 really should have a particular surgery, but maybe their medical comorbidities preclude them from having that. And that has to be weighed in, because if we say here's an absolute guideline, then suddenly we may kill that patient who is physiologically not able to undergo such a procedure. So that's where I think that we have to say here's guidelines, but we have to be careful how we weigh that in for a particular patient, realizing that there are extremes on all ends of the spectrum.
Thank you, Professor. Next segment, as a young surgeon, as a young resident or a young researcher, we always feel like during our residency, from both academic or clinical perspective, what foundational skills one should achieve or develop to contribute significantly and meaningfully to the spine trauma research?
Yeah, I think that I honestly look back at my own career and go, mentorship is such a massive factor. You know, I remember as a medical student, as a resident, as a fellow, even as an early practicing surgeon, that I thought I was just going to jump right in and be the greatest researcher ever and do stuff. And to have somebody to walk alongside me and ask those hard questions and sort of say, hang on a second, like, you haven't thought through this thoroughly enough. You haven't really looked at what this means. You haven't looked at the cost commitment, the effort commitment. You haven't realized your follow-up's not adequate. These are the hard questions that I think are key. And so I think it's nice when you're starting research to really come alongside somebody. And again, I think this is the great thing with AO. You know, you look at the knowledge forums and it's like, people don't start at the steering committee level, they start at an associate level and can kind of be guided through some of those pathways. And so I would recommend to people who really do feel that research is going to be part of their career. And I think to all of us, it helps us to, as clinicians, if we have at least some baseline component of research, I think it does help us to make us better clinicians and surgeons as well. But I would say for anybody launching out, start with something relatively straightforward, and then take that straightforward, discuss that in detail, because there's nothing quite as frustrating as writing what you believe is a great paper and find out that, whoops, the methodology was incorrect, the results were not significant enough, and suddenly you have a 200-hour investment of your time that you can't get published, that nobody really references, that nobody really cares about. So to really take advantage of mentorship, to take advantage of people who've walked in the trenches before, and that's not necessarily a surgeon. I think, you know, my greatest advisor has probably been one of our research assistants, who she herself has written over 1,000 papers. But to kind of sit there and really be that person who says, you don't know what you're doing. And it's like, well, who are you to tell me you don't know what you're doing? But she was 100% right. And then with her guidance, I was really able to create something along the way. But I would advise people to really, you know, find those people who can really help them. And then from that, I think you can grow from that.
Oh, that's some great words of wisdom there. So my next question is, trauma studies aren't one size fits all, right? There's a lot of variation. So when you create protocols for cervical, thoracic, or lumbar injuries, what anatomical and clinical differences do you consider essential? Like the key summary, how they are different?
Yeah, I think that, that the spine is very unique. And I guess, in some ways that, maybe a femur is unique too, because you got the femoral head, you got the femoral neck, you got the trochanteric region, you got the shaft, and then you got, the distal component. I think spine is kind of similar, and we realize that the craniocervical junction, anatomically and from an injury standpoint, is very different than the subaxial spine, is very different than the thoracic and lumbar, and even low lumbar is different than sort of the classic end. And we wrote a paper many years ago looking at low lumbar burst fractures. Anything below the L3 pedicles as being very different from a T12L1 injury because sagittal balance plays so much of a key role. And so I think in breaking these apart, I think the AO, again, this preceded my time, did a fantastic job in sort of saying there's sort of the basic thoracolumbar, there's the subaxial, there's the upper cervical, and we need to look at these things differently, and therefore we have the different classifications and different ways of looking at it. Even within that, I honestly believe that the AO thoracolumbar classification supersedes everything and really does give some great guidelines. It's not 100% perfect, but when you look at the craniocervical junction, that classification and those guidelines there are a lot less clear, um, just due to the differences in the anatomical structures there. And so I think that there are a lot of questions that are even specific to a particular zone, like C1 ring injuries. We're not talking about C2 and C1. We're not talking about C1 and occiput. C1 ring injuries, because it's a unique piece of bone that behaves completely differently, has a different function, we need to look at that differently. And so I think that this gives us a tremendous opportunity in terms of research. Again, for some of these fractures, the patterns are just not common enough to say, oh, here's 1,000 and we can kind of discuss them. But it does give us great opportunity to say, and it also, I think, makes spine trauma a lot of fun because it's not just bread and butter, the same thing time after time. It's like we have to understand and we have to think differently, level by level. Even a facet joint versus a vertebral body fracture, it's all very different.
I totally agree there. Yeah, that's something a lot of us can implement into our next studies. So I think we all had this moment, right, where we're just starting out and we want to know what's the next big thing in spine because we want to write about it. So everyone wants to do work that matters. What strategies do you personally use or recommend for identifying new research questions in the spinal trauma that are both clinically relevant and also academically impactful?
Yeah, I think it all starts with sort of our own clinical practice. We're all sort of seeing one patient after the other. And, from a trauma standpoint, some patient shows up in your emergency room and they have a fracture. You can name any location, you can name any associated neurologic deficit that goes with it. And you sit there and go, are my guidelines, is our academic understanding of this truly black and white? Or does this patient somehow fall into some gray zone where we just don't really know? Or, I've always treated it one way, but I know my partner in another country, in another city, would treat it completely differently. And we debate these things over dinner, we debate these things over email, whatever it may be. That is, I think, a good starting point in terms of where to go. Because if you're asking questions about how to treat something, you can almost guarantee that other people are asking similar questions or should be. And so if you start there and say, I don't know what exactly to do with this. This is maybe something we could study. Do I believe I have the volume in my own center to study this? And if not, do I make this a multi-city, multinational, international study where we kind of bring this to the knowledge forum or whoever and say, let's run a study off of this to try and better understand this. And for the A3, A4, as common as those fractures were, it was a fantastic opportunity because we had this equipoise group where um, we realized that people were treating them differently around the world. It's like there must be some better answer than just sort of, well, we can do this, that, or the other, and it doesn't really matter. And so I think, again, back to your question about designing studies, it all starts with patients you see, and that then allows you to critically think. And I think a lot of people don't really think about that. They look at it and go, well, maybe this will work, I'll just give it a go, and you almost forget about the patient. We really need to care about our patients. We need to care about what's best. And particularly in academics, if we're not going to be the ones to answer those questions, nobody else is going to answer those questions. And so from a societal standpoint, we're kind of obligated to do that. And I think in academics, that should be why we're going into academics, is yes, to train the next generation and to take care of the complex, but equally to say we should put ourselves in a position where we really take that pressure on and really want to step up to the line, run that race, and do the best we can to answer that question. And for every question you answer, you're going to realize that there are 5 questions that still aren't answered, and that allows you to kind of leverage into the next study.
That was a wonderful answer, Professor. And as a practicing spine surgeon, we always get this dilemma when there is a A4, like completely burst fracture anterior, as well as like superior and inferior plates are fractured. There is currently a dilemma in one spinal surgeon's mind that should we go anterior, do corpectomy and just fix one level above and one level below, or go posterior, fix 2 level above and 2 level below the fracture. So how to solve this dilemma? Which approach is better, whether anterior or posterior? How you can solve this?
Hmm. I think it's a very pertinent question, and you know, it's interesting because the A3, A4 really kind of started out with sort of that mindset of, you know, what's the best way. And we realized that as good as the AO classification is in terms of A3, A4, we've actually just launched into the next phase of it. We probably have published already at least 15 articles off of A3, A4. But the next phase is that as good as A3 and A4 is in terms of differentiation, we all realize that there's a component of how much kyphosis is there, how much comminution is there, and there's a lot of other metrics that we measure and weigh in that we have to calculate and are part of the equation as well. And so we're actually doing a study now, going back and looking at 186 CT scans, X-rays, pre-op, post-op, to try and work on all this. And I probably spent 4 hours just this past week measuring X-rays, measuring CT scans to try and glean some of this information as part of a larger group to look into this. In terms of who should have anterior, who should have posterior, this is again a question that I wonder that we will ever truly have the answer to. You can say, well, here's an A4, and you can say, well, in my mind, this A4 has 5 degrees of kyphosis. It's relatively well opposed, and the patient's bone quality is fantastic, and their BMI is 20, and it's at T12. Versus, well, this patient has a BMI of 40 and they're 60 years old and their bone density is much worse and their A4 has a blasted component and they're already looking at, you know, 20 degrees of kyphosis. That's a completely different animal from sort of the first one I described. And so I think this is where I honestly foresee that AI is going to have a role in this, where it's going to say, as we look at all these things that we subconsciously weigh into consideration, the patient's age, their career, their comorbidities, the nuances of comminution, kyphosis, canal intrusion, so on and so forth, that AI will probably give us some sort of protocol to say, all things being equal, you can go 1 above, 1 below, 2 above, 2 below. This patient should have an anterior, posterior. This patient can have an anterior only. I think we will have a little bit more direction because for all of my experience, for all of your experience, AI can take our collective experience and hopefully put that all together to kind of give some pretty good recommendations.
That's really wonderful way to approach it, Professor Bransford. Really well explained. Again, the AO gave classification, the TLX classification, which we follow for the trauma patients. And the real dilemma is when the TLX is 4, and most of our patients end up in that criteria where the score is just 4, and the score tells, well, it's a surgeon's choice whether to fix or continue non-surgical management. When we, like the data says, if we treat non-surgically with conservative approach, there is always a chance that the kyphosis will increase and patient might have the sequelae of the neurological deficit because of the progressive kyphosis. So what's your thought on when the TLX is 4, when we conserve or versus where we operate?
Yeah, that's very interesting to look at the whole evolution of classifications. And you look at the players who created TLIX, and obviously Alex Vaquero was a major player in that, and then the new AO classification, and you almost see the evolution of a lot of the criteria of TLIX, the neurological component, playing out in the newest AO classification. And I think that I was part of the TLIX classification back when it was the spine trauma study group back in I guess it was the late 2000s, early, it sort of, I think, dissolved about 2010, give or take. And I think that a lot of these classifications were made retroactively, where the experts sat down together and said, okay, we all agree we should operate on these, we all agree we shouldn't operate on these, so let's put these at the extremes of, oh, this is always going to get a TLIX 7, this is always going to get a TLIX 2, and that way it sort of meets our understanding of what to do. And almost intentionally, the TLIX 4 fell into that category of, we will all sit around and debate these fractures forever, so let's put these in that equipoise category of a TLIX 4. And that way the surgeon, the classification doesn't give guidance. The surgeon then has to use their own metrics and their own understanding to figure out what to do. And so, again, the classification didn't come out and everything fit in. It was more like people took all the fractures they'd seen and then backtracked to create TLIX. I think, again, this is where, with the newer studies being done by the Knowledge Forum, that this TLIX 4, and I think, how many people even use TLIX these days is a little bit, it's a good tool, but I don't think it's being used nearly as often as sort of the new AO classification. I think this is going to go away, and really maybe we're going to have a TLIX 4 plus and a TLIX 4 minus, where we're going to better understand to say these are ones that should have surgery or should not have surgery. But there's still questions that we clearly don't know the answer to. When we sit around for our day-long meetings in our knowledge forum, we debate and argue and fight in a polite way with one another about all these ones that are really in the TLIX 4 category.
That's such a beautiful explanation, Professor. And I'll hand over to Regis for the closing remarks.
Yes, thank you very much. So, Professor Bransford, this has been incredibly insightful. I think everybody got wiser than in the beginning of the talk. And before we conclude, I'd like to ask if you have any final words of advice for early career spine surgeons who want to make a meaningful academic contribution.
Yeah, I think that, along the topic of what we've chosen to discuss, research is amazing. And I would suggest that, that if everyone has the opportunity to get involved, and I realize that not everybody does, it really, I think, sharpens our mind, and we can go all the way through medical school, residency, fellowship. We can jump into our careers and just sort of say, well, I'm going to be the same surgeon I was. For me, when I started my career over 20 years ago, do I really want to be that same person, or do you want to be that person who, maybe not in a massive way, but inches our understanding, inches things forward as we sort of strive to make our patient care better? And so I would encourage everybody, get involved in research, leverage the opportunities that are available. And for many people who don't have those opportunities at the institution they're at, the joy of AO is that, there are people who are willing to jump on board with you. There are studies being done that are that you can easily get involved with. But take that opportunity to sort of be part of it. I think it'll make you a better caregiver, a better clinician. It'll make you think differently as you read literature, and it'll also make you think differently as you care about your patients, because you're always wondering, is the understanding we have, whether in the literature or from my mentors, really accurate, or can we do a better job at taking care of people? And so I think it keeps us active, and I think as learners, we should never stop learning. And I think that I see far too often in my colleagues here, at least in this country, that people are they stop learning. And at age 60, they can be the same surgeon they were when they were 30 or 35 and started their career. You always want to be making those changes, understanding those changes, being familiar with the literature, and on some level, to the best we can, contributing toward that literature to change the world and make it a better place.
It was really an absolute pleasure to have you, Professor Bransford. We have been reading your research of the team for years, and It's an honor, a privilege to interview you, and we all love. Thank you.
Well, thank you for letting me join, and yeah, good luck to all of you, and hope you all have a good evening.
Yeah, thank you, Professor Bransford. This one's for our audience. If you enjoyed this recorded session, please feel free to share it with your colleagues or trainees who might benefit. And to stay posted for further videos from AO Spine Youth Club, you can subscribe. I believe it's down below in YouTube and also on our social media platforms on Instagram too and LinkedIn. Now, Rares, final remarks.
So we would like to see you guys again at the next episode of Academic Talks. So stay tuned. Thank you very much to everyone for being a part of it.
Bye. Take care, everybody.
Thank you very much.